Well, listen, thank you very much for having me with you today. And so I'm going to do a whirlwind tour on our experience here in the United States and what it meant for public health and the health of our public. Just remind you that the big one was as we thought of was in 1918 and 1919. This quote in the middle here just shows that even here in the United States, our nation shut down in a variety of ways, including our stock market and most of our cities because of influenza. And the question was, how prepared were we for this next time that it happened? I remind folks that in the early 1980s, the world began to see another pandemic, by the way, which is still here. And this also remind us, despite lots of money and lots of effort, we still don't have a vaccine for the HIV/AIDS epidemic. So it was quite interesting that we thought we could create a vaccine for COVID in record time, a new disease that just we had in many ways just seen we thought for the first time. During my time in public health, we had West Nile virus in 1999. Not a lot of deaths, but a lot of concern about this virus as it went through our nation and entered the United States for the first time. I was a health officer in Maryland during the anthrax letters of 2001. And although we only had about 20 cases and over 5 deaths, it really paralyzed our nation for almost 2 months. We had H1N1 in 2009. And although this was a new case of influenza, it was a global pandemic, which resulted in a large number of deaths all around the world. I think what was significant about H1N1 was the fact that many of the deaths were in younger people than we had seen before. And it was a real concern as we saw young people dying, very much like we saw in 1918, 1919. And just to again remind you that pandemic flu has always been a concern. And a lot of us have been preparing for the big one for many, many years. But fundamentally, we were concerned about the big one from influenza. And yet, in 2014, we saw MERS. The good news is, despite the lethality of MERS, it wasn't easy to catch. We had the Ebola outbreak in 2014, which in the United States only resulted in a few cases. But it was a significant issue, particularly in East Africa and West Africa. We had Zika, which hit our continent here in the United States. And quite frankly, we didn't get a lot of concern about it while I was in Brazil until we began to see these babies with microcephaly. That raised a lot of concern because of its impact on pregnant women and babies. And then we had SARS. COVID-2. I think the interesting thing about SARS was the fact that we certainly had seen the SARS virus before. And I would argue that because of all these outbreaks that we had, and lots of talk about how we strengthen the public health system in the United States to address it, we should have known and we should have been prepared. And I would like to argue that for a variety of reasons, we were not. So in December of last year, when the cluster of severe pneumonia cases hit the city of Wuhan, China, and then we rapidly saw, as you can see from this timeline, that from December 30th through January 20th, we already saw a substantial increase in this disease in other nations. So in January 13th, Thailand saw it. In January 19th, Beijing and other cities in China were beginning to see it. In January 16th, it hit Japan. We were in the United States, we were kind of watching for it. And interestingly enough, we were watching for it to come and hit our West Coast. And quite frankly, it did come to our West Coast, but the biggest insertion of this disease actually hit our East Coast, which we weren't really watching for. And then, of course, we now know that this was a pandemic that hit the whole world, which was eventually declared by the World Health Organization. I would like to argue that we really had 3 pandemics. We had the infectious disease that we were very much concerned about. We had a huge infodemic, which was about misinformation and disinformation, which has really driven this disease process in a variety of unhelpful ways. And then a real epidemic of fear, fear of the unknown, fear because it was a rapidly moving communications environment. We had really poor risk communication, lots of fear, at least in the United States, of persecution, and the lack of a unified national voice and loss of trust because of our political leaders managing this, even at the highest level of our nation. We knew very early that there was a respiratory disease and that it was transmitted, by both droplet spread, and the big debate about aerosolization really isn't a debate we probably should have had. We knew that you actually can get aerosolization from this. The question was about whether or not this disease acted more like an aerosolized respiratory disease or more like a droplet disease. And in retrospect, it appeared to be more of a droplet type of disease with some aerosolization as possibility. And, we spent a lot of time worrying about fomite transmission, which turns out have not really been a big deal as part of this disease process. But we spent a lot of money, time, and effort cleaning things and being concerned about how you caught this disease from surfaces. We knew early on that containment strategies, like most of these infectious diseases, work if you have a good test and you can figure out how to isolate people, quarantine people, do effective case finding that you can actually box this disease in. Although we did a lot of this early on in the United States, it wasn't as effective as it needed to be. And in fact, this ultimately grew very quickly to be a disease in which we had to manage through the medical care system and not necessarily our governmental public health system as we would have liked to have done. We did know early on that these non-pharmacological interventions would be successful to some degree because that was all we had, hand washing and respiratory etiquette and social distancing and keeping ourselves away from each other through a variety of methods made a big deal. We're going to talk a little bit about facial masks in the United States as part of this as well, because that was something that we really underestimated the value of masks early on. We had lots of studies that people looked at to see how long this virus lived on surfaces. And in many ways, this drove us to do, I think, some very non-productive things in terms of worrying about how you got it, as I mentioned earlier, about cleaning things that we probably didn't need to worry about cleaning. But nevertheless, we knew that hand washing worked, and it always works. It's one of the most effective prevention tools that we have, and we promoted hand washing a lot in our nation. Masking became a very significant political issue. It defined you politically, whether or not you were on the progressive side in the United States or whether or not you were on the conservative side of the United States, often was determined by whether or not you wore a mask, and that was driven by the politics. Everyone's, I think, has seen this very famous picture of a cough and sneeze, and as you know, generally when you cough or sneeze, the material that comes out of your nose and mouth goes about 6 feet, which is why we always have that kind of 6-foot magic barrier, but it can certainly go further. And clearly, one would think that putting any barrier in front of your face would be effective in reducing your risk from this. But in the nation of the United States, we had a big debate. Initially, we told people that you shouldn't wear a mask. And that was for 3 reasons. Number one, we thought that SARS-CoV-2 would behave like SARS-CoV-1 with no asymptomatic spread. That turned out to be wrong. We were also concerned about self-inoculation of people messing around with their mask and therefore self-contaminating themselves. We also wanted to preserve the N95 and surgical masks for health workers because we knew we had a shortage of masks. And one of the biggest issues in the United States was the issue around surgical masks and N95 masks for people who were in very intense environments taking care of patients. Now, wearing a mask is not new. This is from the 1918, 1919 influenza, where in many parts of this country, you can go back and find lots of press clippings where we told people to wear a mask. And over time, we realized that even a cotton mask would work as part of our outbreak. And many of our health officers did studies like this. This is Arizona, where the governor did not require people to wear the mask, but did not prohibit local jurisdictions from putting people in a mask. And so what you can see in this, frankly, real-time study, where the blue line shows that in counties where people were not required to wear a mask, they had a persistence of the disease. The red line shows that in those counties where people were wearing a mask, they had a dramatic fall off of infections. Masks work. We know the mask protects both parties. It protects me from you and you from me. And of course, we've always known that we have this anti-mask resistance, which we of course even had this many, many years ago, even during the great pandemic of 1918, 1919. In the United States, we had a specific problem around racial profiling, where we had African-American men who were already being profiled in a variety of settings, who were very concerned about wearing a mask. I mean, you can imagine being an African-American male going into a store wearing a mask. And we had situations where people of color were escorted out of the store because they had a mask on. At the same time, they did not escort out the store non-African Americans, basically non-Hispanic whites. They allowed them to wear the mask in the store and participate in activities in the store. And also, obviously in the United States, people were very concerned about wearing a mask. If I was, I talked to a lot of my friends, I would not wear a mask going into a bank because I would be concerned about being accused of being a criminal. We also knew that flattening the curve was very important. If anyone has any doubt about the importance of doing that, look at what's going on in India right now. We were successful in the United States, although it was a near miss in terms of reducing our footprint with disease by doing everything we could by closing our society up. This started first in the San Francisco area of our country, where the health officers got together and started closing things and encouraging social distancing with some degree of deliberation and aggressiveness. And we were very successful in actually reducing the disease and disability we had from COVID by doing that. We knew that this worked. This is a graph from the 1918-19 epidemic. These are two cities in the United States. We were trying to make sure that people were more like St. Louis and not like Philadelphia. The city of Philadelphia continued to have parades, did not shut down their community, and that had a huge spike in deaths in Philadelphia. Where in St. Louis, they did. And you can see that they were very, very successful in reducing the death rate in the city during 1918. We also got better over time with therapeutic interventions. General supportive care was all we had initially. We learned that we should not intubate lots of patients. There were many ways to maintain the oxygen level of patients by turning them on their stomach sides, turning them on their stomach, learning how to manage their airway more effectively. We got a lot better at coming up with reducing the inflammation from the disease using steroids. And like many of these diseases, learning to use antibody-rich plasma and monoclonal antibodies. But these were lessons that we learned over time to try to improve the therapeutic interventions of the disease. Today, we've got, globally, we now have over 162 million cases and 3.3 million deaths. In the United States, we have today about 32 million cases. And we are per capita not doing very well in terms of cases, although that's gotten better, and almost 600,000 deaths. And what's important is that these are these 585,000 deaths you see here that we have had almost over a little bit over 1 year was more deaths than we had in all of World War II, which lasted 6 years in the United States. So this is a significant number of deaths that we had from this disease. We know that the epidemiology of this disease over time was that most of the cases had mild symptoms, but about 15 to 20% of the people had a severe disease. And although the case fatality rate isn't exactly final, it's somewhere between 1.5 to 3.5% of the population actually died from this disease. We discovered this was more than a pneumonitis, that this disease, because of the immune functions of the disease that it precipitated, it resulted in heart attacks and strokes. It created clots and immune dysfunction in a variety of ways, and has a chronic syndrome, which is now called the long haul syndrome, which we're still trying to better understand. that it certainly has a row of approximately 2 overall, but there are certainly super spreaders out there. It was clearly more infectious than most influenza strains, and we had profound asymptomatic transmission, between 25% and 40% in our communities, depending where we are. And one of the early findings was disparities by race and ethnicity emerged very early in our country. We see this here in this slide from the Center for Disease Control and Prevention, which shows that Native Americans and Alaskan Natives had a case rate of about twice of everyone else, hospitalizations of 3.7% and deaths almost 2.5%. That if you're African American, that your hospitalization rate was also elevated, almost 3 times the hospitalizations and almost 2 times the death rate. And other ethnic groups, as well as Hispanics, and even some Asian Pacific Islanders in our country had elevated rates. And one asked why that is. It was not because of the color of your skin, but we did see that from a practical perspective, that life expectancy was dramatically impacted. For all of our races, life expectancy diminished by about 2 years. And if you're a non-Hispanic Black male, life expectancy was reduced by almost 3 years. By Hispanic males, almost 2.5 years. And you see the numbers there for females, almost the same thing for Black females as Hispanic males. Significant reductions in life expectancy because of this disease, not just because of deaths from COVID, but also from other diseases that occurred and we weren't able to get to and treat. So the all-cause mortality was significant in the United States. The reason for this was because of the social determinants of health. We knew that these communities were much more likely to be exposed because they had public-facing occupations. Communities of color were much more likely to be bus drivers, or work in grocery stores, or work in nursing homes, which were heavily hit in the early part of the pandemic. There was also some delayed sheltering in place because of misinformation, where people thought in the African-American community, as an example, that we did not get this disease. Susceptibility because of prevalence of chronic diseases. So we knew early on from China that if you had heart disease, lung disease, kidney disease, or diabetes, you're much more likely to get very sick should you get infected. So in the United States, we have a disparity in these diseases in communities of color. So when they got infected, they were much more likely to get sick. And then a range of social determinants. And many of the occupations did not have paid sick leave. So you went to work ill. And then if you got sick, you went home. And if you didn't live in a mansion, you were much more likely to share this in your home because you had maybe 2 bedrooms and 1 bathroom. And it's very difficult to isolate and quarantine, even if you know that you have COVID if you live in a small house. And then racism and discrimination in many ways, particularly structural racism, played out to a large degree. And I'm going to talk about that a little bit when I talk about vaccinations in the United States. So as we looked at vaccinating people, one of the good things that the Trump administration did do was they did something called Operation Warp Speed. I'm a Star Trek fan, so I didn't mind that word, but for many people, that designation was a terrible choice for the program because it implied that we were moving this thing fast, and many people thought that we were undermining the science, which we did not. We just moved the bureaucracy out of the way. But at the end of the day, it turned out it was a sound strategic decision to accelerate vaccine discovery and access to vaccines because we made financial investments in partnerships throughout the process. And to that end, unlike HIV/AIDS, we were able to come up with a strong vaccine. This is a picture of the first person in the United States to be vaccinated. There was not an accident that the first person was a nurse and was an African American. The symbolism was designed on purpose to try to address the issue because we had a lot of vaccine hesitancy in communities of color. We also knew that we didn't have enough vaccine coming out of the gate initially, so we prioritized who would get the vaccine, and they prioritized healthcare personnel and people in long-term care facilities. We did that because the healthcare personnel needed to take care of all the rest of us, and we had a high mortality in people who were in long-term care facilities. They were about 80% of the deaths early on, and we felt it was important to vaccinate both the residents and the people that worked in the nursing homes And then you can see we worked through a variety of other groups in the country. And we now allow everyone 12 years of age and older to be vaccinated in the United States. We had some early barriers from this process. Lots of misinformation and disinformation. As I said, it went from people reporting that there was a tracker in the vaccine so that the government could track you, that the disease would give you AIDS, that the disease would cause you to become sterile, that would impact your fertility, all kinds of misinformation. And then we had the usual anti-vaccine advocates who are actively out there trying to undermine our confidence in vaccines. This became politically sensitive very early on between our conservative and progressive communities. We knew we had an inadequate infrastructure for our basically governmental public health. And we had real poor implementation planning, even though a lot of strong work on the science of vaccination, the implementation planning was slow and inadequate. And that resulted, just like in the disease, in differences in who got vaccinated early on in the United States. And by the way, many of these disparities are persisting. So in the communities of color, big concerns about the speed and development of safety, distrust in government. There are a lot of concerns about the politics and the economics. Even though we did have very diverse clinical trials, we needed to explain the fact that normally communities of color are not adequately represented in clinical trials, but in this case, that was not something we should be concerned about. We worked very hard to make sure there was diversity in the clinical trials. And then, of course, fear-based activities because of prior things that had happened. And many words were used in the communities of color. They did not want to be viewed as guinea pigs or being used for studies. So we had a lot of work to do to try to address this. My organization worked with a group called the Ad Council and the COVID Collaborative to come up with a campaign. And so we have a big national campaign in the United States called It's Up to You to get vaccine answers. The National Academy of Medicine has many of their African-American members got together to promote vaccine utilization in our communities. This is a newspaper article which pointed out that, it's one where I was quoted in, but pointed out that even a university that wanted to vaccinate all of its employees found that there had disparities in who got vaccinated. The doctors and nurses understood about vaccination. Many of them may have still been hesitant, but they had access to the hospital email, so they got the communication about getting vaccinated. But if you were a food service worker or a maintenance worker, many of those individuals who also had even greater concerns about getting vaccinated, they did not often get the information. And so the effort resulted in disparities, even in a place where we wanted to get people vaccinated. So we had a lot of work to do. And so we've worked very hard to try to address some of those structural barriers. One of the more interesting ones, of course, was the fact that if you didn't have access to online registration, a lot of the places to get your vaccine appointment were online. So if you didn't have access to a computer, or if you did shift work, if you're a bus driver and you worked a shift, by the time you came home in the afternoon, all the vaccine appointments were gone. So you couldn't get an appointment. And that remained a big problem throughout the early part of the vaccination effort. Also, we learned, of course, something we've known for many years, that it's not just the message that has to go out, but it's also the messenger. And so building a fleet of trusted messengers to encourage people to get vaccinated became a very important effort in the United States. So when President Biden became president, they initially had a goal of vaccinating 1 million people a day. Of course, we knew that was not going to achieve anything close to getting us to herd immunity. So they increased their goal to 2 million, and at one point ultimately got to 4 million vaccinations a day, although that's now dropped down to about 2 million people a day. They sped up what we call something the Defense Production Act. Excuse me, this is our government being more involved in supporting vaccine production and working with the companies to produce more vaccine, as well as testing supplies and equipment. They've begun working on improving the appointment systems, increasing the number of people who could give shots, including bringing federal employees into the effort, and increasing the locations for vaccination. So now you can get vaccinated at any of the retail pharmacies, at your doctor's office. Although that still remains a little bit of a challenge. Lots of mass vaccination sites, community health centers, et cetera. You can now get vaccinated in the United States. So to date, we've delivered about over 273 million shots. About 50% of our population has gotten one dose, and about 44% has gotten two doses. The United States has a goal that by the 4th of July, our Independence Day, that we will have 70% of our population have had at least one dose. We're on track to get there, but there are still some challenges. And we're hoping to get 60% of our population fully vaccinated. So let me talk about a little bit about what we learned. We learned that public health operates in an incongruent fiscal environment where something happens, they begin to put some money on the table, usually late, and then there's an expectation that we continue to perform. We know that's true, and that's a real problem here in the United States, and I suspect that's also a problem for you in Canada, because this is what they did on funding. In the early 60s and 70s, they put lots of money into the public health system, and then over time, they let that funding fall away. This little increase around 2000 is a little bit of a bump we saw after 9/11 and the anthrax letters. And then they increased it with each time we have a bad outbreak, and then they really haven't really invested. So we've lost substantial capacity in the United States. We've had a huge loss in jobs. This is the loss of jobs of just state public health workers. And if you look at all the jobs we lost in the United States, we've lost over 50,000 public health workers. We still have major data problems. During this outbreak, we had lots of our local health departments which were moving pieces of paper by ink and fax machines. So our antiquated systems of surveillance and data remain a real challenge. Again, lots of money was pouring into our systems early on after the 9/11 and our anthrax letters, but that obsolescence and the resources have not kept up in the United States. We also know we had multiple systems failures with poor and confused federal leadership, early technical failures with the PCR testing that the CDC put out resulted in some delays. I talked about the understaffing, but I think the biggest issue that we had was we had lots of plans and reports that we've had on the shelf for many, many years that have not had any action. And of course, the World Health Organization just looked at their efforts on a global scale, and the number of plans and recommendations, even on a global scale, have not been implemented, which I think tells a lot about the real challenges we have as we go forward. And then, of course, the United States, we're still the only industrialized nation in the world that has not figured out how to have universal healthcare coverage for all of our citizens, which played a role. We've heard very clearly that epidemics are complex issues, which our leaders always have difficulty managing, that these random terrifying events can happen, but their people are quick to watch what's going on, but really not quick in understanding what to do. That these diseases tend to be mysterious, and they can trigger a range of actions in people. Sometimes they're not productive, sometimes they are. That our modern systems of being in a globalized world means that we have globalized information, and so these round-the-clock reports and social media create a range of communications issues. The fact that we're only one plane ride away from a major outbreak. We saw that with Ebola. We saw that with H1N1. We saw that with SARS-1, and we certainly have now seen that with SARS-CoV-2. We also know that these have enormous implications on the fiscal well-being of our nation, and this is not new. We've known this for some time. We've also known that our health system, which now leans with very lean budgets, and just-in-time supply systems did not serve us well during this outbreak. We know there are all kinds of trade-offs, that the normal health needs don't go away. And so we have many people now who have delays in their cancer screening, childhood immunizations, lots of underlying health problems that have not gone away. None of the epidemics that we had pre-COVID with opioids or obesity or HIV and AIDS, as I mentioned earlier, or our gun violence epidemics, those didn't go away. They just got suppressed. We also know that this fact that we have to really reconcile in our country about the health versus political and the economic drivers needs to be better understood, that good public health is good politics. It's also good economics, but we really had a difficult time making that case. Misinformation is not new. This is a 1930 cartoon about misinformation during the smallpox outbreak. This is in a book called Health in Pictures that was actually published by the American Public Health Association. There's actually a French version of this cartoon as well. I mentioned earlier that we had lots of false information that drove people not to take the disease seriously. And we had lots of recommendations that we've now come up with around the response. We know that we needed to engage people, particularly in communities of color, much earlier than we did. We needed to work harder to build trust. We needed to make sure people had access to services, because one of the challenges we had was that while we were testing people early on for the disease, we often did not provide them the healthcare access that they needed because of, again, the United States fractured system. And a lot of people, again, the messengers were not necessarily people that looked like them or were from their community, and that resulted in some real problems as we went forward. We also learned a lot about what our health practitioners needed, that we needed much more uniform national guidance. I, for one, was early on okay with some of the fractured guidance, but it turns out that that was a mistake. And we needed to do a better job of engaging our local NGOs as part of the process. And many of the quarantine decisions that were made were not necessarily driven by science, and they needed to be driven by science and not politics. We've had lots of reopening issues. Everybody's having quarantine fatigue. We continue to have politicization of the response. I mentioned the issue about wearing masks. Now we're having the debate about taking our masks off. Before we had the debate about putting our masks on. We still aren't clear about when tests should be used. We're having a national debate about vaccine passports and mandates in our nation. We're going to have to work those out the next few weeks. And then we still have a lot of public anger and distrust that has been resident throughout the outbreak. We know that at the end of the day, the communities want to know when their kids can go back to school, when their kids can go back to camp, when they can go back to the building to work safely, and how better to treat people who are exposed or at risk. We still need some better therapeutics as we go forward. There are many things we still don't know. For those of you who are researchers, we don't know what the final mortality rate is because we don't know what the denominator is. You know, there are a lot of people that got infected that never had symptoms, and we just haven't done a really good job of understanding what the real prevalence of this disease is in our society. We don't know whether it will be a seasonal disease or episodic. Is it going to become endemic? I believe that more likely it will become endemic. We don't know the role of children as carriers. We know that children are big carriers for influenza. We don't really know their role for sure at COVID. We know very little about this long haul syndrome, the pathogenesis and its clinical course. We're now studying it, and many other nations are as well. We don't know what the variants and their impact will be at the end of the day. We do know that the current vaccines do deal with the variants that we have today, but a lot of concern about what those variants will look like in the future, whether our vaccines will work, and whether or not we'll need a booster. And of course, as I mentioned before, the best way to treat this disease remains a real enigma. So with that real run through, let me stop, and I want to thank you very much.